The commonest causes of wheeze in young children in developing countries are acute respiratory infections, such as cough and cold, bronchiolitis and pneumonia, and asthma. Since pneumonia is a major cause of death in young children in most developing countries, it is particularly important always to consider this diagnosis in children with wheeze. Having examined the child presenting with cough or difficult breathing, and recognized that the child has wheeze, decide upon the correct treatment for that child. Wheeze is caused by narrowed air passages. In most children, this is due to inflammation of the airways and a spasm in the muscles in the walls of the airways. This spasm should respond to treatment with a bronchodilator. A bronchodilator is a drug that helps these children breathe more easily by opening the air passages of the lungs and relaxing the bronchospasm. An essential step in the assessment of children with wheeze is to look at the response to bronchodilator treatment. It is important that small hospitals have not only oral salbutamol for the treatment of mild wheeze, but also a rapid-acting bronchodilator available. Rapid-acting bronchodilators produce a response within 15 minutes, allowing you to make an assessment of the child's wheeze within a short time. They are particularly useful in treating children with severe wheeze and in helping to decide the cause of the wheeze. Those who respond to bronchodilator treatment are likely to have asthma, whereas those who do not are more likely to have pneumonia or bronchiolitis. It is therefore important that rapid-acting bronchodilators be available in health centres and small hospitals, that the right equipment be available to use them properly, and that doctors, nurses and other health workers are trained to administer them correctly. There are three methods of giving treatment with rapid-acting bronchodilators for the assessment and treatment of wheeze that are recommended for use in health centres and small hospitals. These are the inhalation of a salbutamol aerosol or mist using a metered dose inhaler or a nebulizer, or through the injection of epinephrine, also known as adrenaline. In most circumstances, inhalation using an aerosol is the most effective and safest method of delivery. The two methods of aerosol delivery currently available are metered dose inhalation and nebulization. An additional method used by adults and older children, dry powder inhalation, is ineffective for most infants and young children. The metered dose inhaler, when used with a spacer device, and nebulizer have both shown themselves to be effective treatment methods in young children. Most children under 7 or 8 years of age will be unable to use metered dose inhalers effectively when they are wheezing. This is because they are not able to time their breathing correctly to breathe in the salbutamol aerosol when it is delivered by the metered dose inhaler. However, metered dose inhalers can be successfully modified for use by infants and young children with the addition of a spacer device. The jet of spray provided by the metered dose inhaler is trapped in the spacer chamber. The propellant evaporates, leaving only the bronchodilator particles. The small particles are more likely to reach deeper into the child's airways and so be more effective at relieving the wheeze. The metered dose inhaler is placed into the end of the spacer device. The inhaler is depressed twice to generate 2 puffs. The child is instructed to take 5 full breaths with the mouth closed around the mouthpiece. The spacer device creates a reservoir of spray for the child to breathe. It removes the need for the child to breathe in at the moment the inhaler is depressed. A spacer device with a mask can be used with young children who cannot use a mouthpiece. If commercially manufactured spacer devices are not available, it is quite simple to make your own. Very effective spacer devices can be easily made from 1/2 or 1 litre plastic bottles. However, plastic spacer devices can build up an electrostatic charge. The charge causes the salbutamol to stick to the plastic spacer device, reducing the amount available to the child. Washing the spacer device in a household detergent solution or soap before use can stop this occurring. This simple measure can substantially improve the effectiveness of this treatment. To make a spacer device from a plastic bottle, use a pair of scissors or a sharp knife to carefully cut out a shape similar in outline to the mouthpiece of the inhaler. The spacer device is then pushed into the hole you have created. The open end of the bottle is placed in the child's mouth. The first time you use a homemade spacer device, use 3 to 4 puffs. Afterwards, you only need 2 puffs. After this, the child breathes in and out for 30 seconds. The nebulizer consists of a container into which a liquid mixture of salbutamol and water is placed. The salbutamol and water is placed here. A flow of 6 to 8 litres per minute oxygen or compressed air is then introduced here, into the pipe which runs up the centre of the nebulizer. The flow of the oxygen or air into the nebulizer draws the salbutamol and water up the outer section of the central pipe. When it reaches the top of the pipe, it meets the oxygen or air here. The oxygen or air breaks up the salbutamol and water against this section of the nebulizer, turning it into a fine mist. The mist is then forced by the flow of oxygen or air out of the top section of the nebulizer. The child then inhales the mist. It is important that the nebulizer is filled and used correctly. Unscrew the top of the plastic nebulizer and add the salbutamol solution. 0.5 millilitres of liquid salbutamol should be used for children under 5 years. Add 2 millilitres of normal saline or sterile water. If normal saline or sterile water are not available, drinking water should be used after it has been strained with a cloth, boiled for 20 minutes and cooled. Do not overfill the nebulizer. Attach one end of the tubing to the bottom of the nebulizer and the other to an oxygen supply with a flow of 6 to 8 litres per minute or an electric air compressor. If available, a mask or T-piece may be used. The child should be treated until the liquid in the nebulizer has been nearly used up. This usually takes about 10 minutes. It is not necessary to nebulize until all the liquid has been used. In practice, about 0.5 millilitres will be left in the nebulizer bowl. You can tell when this point is reached, as a sputtering sound will occur, and at this stage, little of the residual fluid is being nebulized. After each use, wash the mask, the tubing and nebulizer with dishwashing detergent or soap and dry thoroughly. Do not boil or steam clean the tubing or nebulizer, as this may damage them. Subcutaneous epinephrine, which is also known as adrenaline, is given to young children by subcutaneous injection. It is also a rapid-acting bronchodilator, which will act in about 15 minutes. Great care needs to be taken when administering epinephrine. It is vital to check that the correct strength of solution is used. 1 to 1,000 dilution should be used at 0.1 millilitres per kilogram of body weight. A 1 milliliter syringe should be used, and the dose measured very carefully. Reassess the child after 15 minutes. A child with the first episode of wheezing and no respiratory distress after nebulization can usually be managed at home with oral salbutamol and supportive care only. If the child is still in respiratory distress or has recurrent wheezing, give salbutamol by metered dose inhaler or by nebulizer. If salbutamol is not available, give the child subcutaneous epinephrine. Reassess the child after another 15 minutes to determine subsequent treatment. If the respiratory distress has resolved and the child does not have fast breathing, advise the mother on home care with oral salbutamol syrup or tablets. If the respiratory distress persists, admit the child to hospital for treatment. If the child has central cyanosis or is unable to drink, the child should be admitted to hospital for treatment. All the techniques shown in this video have a role in the management of wheeze in young children. In terms of ease of administration, availability and cost, metered dose inhaler and spacer devices may be the most appropriate method for administering a rapid-acting bronchodilator to young children with wheeze in outpatient facilities. However, in making your choice, you must consider any local factors which may influence your decision.
Big breathing.
Implementing the recommended procedures in this video will allow the correct treatment of wheeze in children with cough or difficult breathing. This is an essential element in the management of children with an acute respiratory infection and acute wheeze.